Good afternoon. Thank you everybody for joining us today. We're so happy that you could be here with us. My name is Tamara Bingham-Noyes. I'm the Director of Business Development at Center for Change. It's my pleasure to be here with Quinn Nystrom, and I'll introduce Quinn in just a minute. We want to do just a couple of quick housekeeping things and get right into it so Quinn has time for her full presentation. So here's some housekeeping items. First, a copy of the PowerPoint is in the handout section of the toolbar. You'll see it there. It's also at centerforchange.com in our webinar, on our webinars page. If you'd like to download it from the handout section of the toolbar, you're welcome to do that so you can reference it later. A copy of the post test is also in that same handout section of the toolbar. This is for reference only. In order to obtain continuing education credit, you must take the post test online. I'll talk about that in just a second. You're welcome to submit questions in the questions section of the toolbar. Because there are a lot of us on currently, it makes it challenging to have everybody's audio and video on. So we have that turned off, but we certainly want you to have the ability to ask questions throughout. So you're welcome to submit your questions, type them in the questions section of the toolbar. I'll monitor those throughout the presentation, and then at the end, we'll save a little bit of time for Quinn to be able to address a few of those questions. When the webinar ends, when I click to end the webinar, an evaluation will automatically pop up on your screen. This is a continuing education requirement for us. It's completely anonymous, so please feel free to be candid in your feedback. We tabulate those results and then send those into the CE entities as part of our requirements for continuing education credit. And then about an hour after the webinar ends, you'll receive a separate email with the link to take the post test. Again, you must take the post test online in order to receive continuing education credit. About an hour after the webinar ends, as I said, you'll get a separate email. It will look similar to the email you received from GoToWebinar when you registered for the event. There'll be a link in there to click to take the online test. Once you pass that test, the CE certificate will automatically be downloaded to your computer. So if you don't see it on your screen, check your downloads file, because sometimes it gets tucked away in there. Okay, we're going to turn things over to Quinn here shortly. Quinn is my good friend, so let me just start with that. Quinn and I have known each other for a number of years, and we've had the opportunity to travel across the country together as Quinn does presentations on type 1 diabetes and eating disorders. We've been sad and missing that since the pandemic and are hoping to be able to do more of that in 2022. So in the meantime, we're thrilled to have Quinn with us to be able to do a webinar. She's an amazing person in every aspect, and she's an incredible advocate for those who have type 1 diabetes. As Quinn will talk about her story, she has type 1 diabetes herself, and she's a phenomenal advocate, especially in the insulin affordability world and making sure that everybody can have access to the life-saving drug that they need. So we're just thrilled to have Quinn with us today. So with that, Quinn, I'm going to hand it over to you. So let me change my sharing real quick. Okay, it should be coming your way.
Okay.
Oops. Great. I see. Oops, nope.
I had it up. There we go.
There it is. They just have to start from the beginning. There you go. I'm going to go ahead and turn off my mic and my camera. But if you need me, I'm right here listening. I'm monitoring questions. Holler if you need anything. Otherwise, we'll connect back at the end.
Tamara and I were laughing just at, you know, how many years now they've been doing these webinars, and then certainly post-COVID, even doing more of these, and just how reliant we are on internet and technology. So bear with us all. We will all hope that there is no technical glitches during this presentation, but please let us know if there's any issues on your end. So I'm thrilled to be presenting today. As a lot of you know, November is Diabetes Awareness Month. We're really trying to heighten the awareness around people living with diabetes, type 1, type 2, gestational diabetes. Again, my lived experience is with type 1, so oftentimes that's sort of the perspective that I'm speaking from. And Center for Change, I've spoken for years with them about, you know, life with type 1 diabetes and eating disorders. And Tamara had asked me this last year to put together some different presentations that I haven't done before. And so One of those actually is this family dynamics topic. It's something I did research on when I was in graduate school about the impact that that plays on adolescents with type 1. I also did a presentation on diabetes burnout, which you can go in the archives for Center for Change if you're interested in seeing that. I did that earlier this year. So I am going to get started here. Oh, my husband is crawling on the floor, so no worries there. Okay, let me just get my presentation up. All right, sorry, he's laughing, but it's the COVID world. So, okay, so I want to start out with a couple helpful diabetes terms. I know on past events I've done, there's a really far spectrum of what people know about diabetes. So my apologies if you're a well-versed diabetes person. I'm just going to quick skim these though, so that we can all sort of have a basic understanding of what we'll be talking about today. So type 1 diabetes, it's the pancreas no longer makes insulin and therefore blood glucose cannot enter the cells to be used for energy. You might have heard of type 1 diabetes in the past referred to as juvenile diabetes. We don't use that term anymore just because we don't use an age to diagnose. Just like we don't say type 2 diabetes, we don't call it adult onset anymore. We just call it type 2. And that means the pancreas does not make enough insulin or the body is unable to use insulin correctly. Blood glucose or blood tests, you'll kind of hear different words around this. That's the main sugar found in the blood and the body's main source of energy. It's also called blood sugar. So that's why there's a lot of focus put on, what is your blood sugar? What are your levels? Things like that. Hemoglobin A1C, you may see it written as HbA1c, is a test that measures a person's average blood glucose over the past 2 to 3 months. So when we're talking about, how is a patient doing? How is somebody doing with their diabetes? Often the hemoglobin A1c is sort of the sort of blood test that can be done to really show medical providers how somebody is doing. Now, obviously, we're trying to learn and grow with different things with new technology coming out. So many of you probably know a continuous glucose monitor, a CGM, that has really changed the game. So again, having a sensor on you, it continuously tracks your blood glucose level throughout the day and the night. So for instance, for me right now, I can actually read on my watch, my blood sugar is 96. Again, in the past, I'd have to, test my blood sugar 4 times a day. So things are significantly better with technology that's come out. And I'll mention this later, but just because we have technology doesn't mean people with diabetes are able to have access to it, because we have huge accessibility issues in the diabetes community, especially right here in America in our backyard. We have accessibility and cost issues when it comes to CGMs, insulin pumps, and then, as I think we all know, insulin. Time in range, I won't use this a lot, but this term is used a lot more now because of the popularity of CGMs. So this is, again, instead of just looking at that A1C, which is an average blood glucose, this is actually looking at all those blood sugars that you have 24 hours in a day. What is the percent that you're sort of within your range? So between 70 and 180, or you may adjust that to 70 and 150. Again, we're looking at a percentage there. Ketones, when the body starts to break down fat in order to get energy, ketones are a byproduct. So again, always looking at that, especially as a type 1, to make sure we don't have ketones in our system. Those are always caused by not enough insulin and too much sugar in our system. Diabetic ketoacidosis, DKA, which is very scary. It's an emergency condition. Again, extremely high blood glucose levels, a severe lack of insulin. Signs of DKA are nausea, they're vomiting, stomach pain, fruity breath odor, and rapid breathing. So untreated DKA can lead to coma and death. So it's, we're talking about life and death things when we're discussing somebody with type 1 or type 2 diabetes. So type 1 diabetes, you have over 1 million people in the United States who have type 1. Nearly 18,000 new cases are diagnosed annually in people under the age, sorry, I'm having some problems here, under the age of 18. The most common diagnosed age, some people ask me this in the US, the peak age is 14 to get type 1 diabetes. The life expectancy of a type 1 is a decade shorter than those without the disease. Again, we've made big improvements leaps and bounds because of technology, but we're still quite a ways back because a lot of things. I think how we view the disease, how others view the disease, and this huge accessibility and affordability issue that we have today. But certainly want to point these things out to everybody just as a basic. So the main thing we're talking about today is family dynamics, and how does that all work? Again, with a very complicated disease. I'll be focusing on type 1 diabetes today, a type 1 adolescent in a family. So that's, I talked with people who, they have an 18-month-old all the way up to, an 18-year-old. So the first concept we're going to go over is illness perception and kind of how this all ties into the family dynamic. But illness perception really is looking at the organized cognitive representations or beliefs that a patient has about their illness. So again, a lot of research done on this, but research findings show on this topic when you change a patient's illness perception. So how does somebody like myself view my diabetes? They can be successful in reducing disability and speeding return to work or to school. What is the internalized feeling that a patient has about their diagnosis plays an integral role in how they perceive what is going on in their day-to-day world, right? So now if I'm a young adolescent who's been diagnosed, typically a parent, a mother, father, mother, father, father, one parent typically plays a dominant role in helping care for that child. So there's a lot of research that's gone into how the parents view the illness. How does that affect an adolescent when they're viewing this disease themselves? So for example, if the parent thinks the child is delicate and very fragile and should be bubble wrapped, that child is going to have more of a sense of feeling that they are breakable and they have to be really careful and cautious. Whereas, right, we'll talk about different ways that you can perceive, obviously, that illness for your children. So, research has shown that the greatest impact to a patient that is being diagnosed with a chronic, so in this case, a chronic illness, is their perceived ability that they will get to still have a normal life. So I have done thousands of interviews with people with diabetes, and when you really ask them, what is it that is the most sort of difficult part to cope with? A lot of them will say, when I was diagnosed, I didn't know, could I still be like my friends? Could I still live this semi-normal life? I know when I was diagnosed, I was in the 7th grade, I was 13 years old. Some of you know this story. When the doctor asked me, okay, you've been diagnosed with a chronic incurable illness, what questions do you have for me? The only question that I had for him was, could I go to the junior high dance that night? Now, it probably seems like an odd question, a silly question, when obviously I've been given some real life-altering news. But again, what I was really asking, what I was really going for was, could I just be like my friends, right? I wanted to make sure that I could still have this quote-unquote normal life. The 5 main components to illness representation. So you have identity, the label or name that's used to describe the illness, sort of the cause. What does the patient perceive as the reason they got diagnosed? Now, you'll hear sometimes with people with type 1 that they feel betrayed by their body, right? So they end up hating their body and can sometimes evolve into other issues like self-harm, eating disorders, abuse of a substance, because they feel like their body betrayed them later on down the road. So again, what is the perception? Timeline. How long does the person believe they will have this chronic illness? Now, we know with type 1 diabetes, there is no cure. Now, you'll hear some horror stories from people, myself included, where we were told by medical professionals right when we were diagnosed that cure would only be 5 years away. Now, again, I'm not blaming any medical professional for saying that. I think, unfortunately, we do that to give people hope. But unfortunately, then when that 5 years comes or that 10 years comes and the cure isn't here, we can see a lot of issues then just, again, about how you perceive this illness that you have and can't get rid of. So consequences, what might happen medically to this patient over time if they don't adhere to the strict medical regimen that they've been given. So we know with type 1 diabetes, you are diagnosed and instantaneously you need to be checking your blood sugar multiple times a day or get a continuous glucose monitor. You need to give yourself multiple insulin injections a day or wear an insulin pump. You have to count, every carb that goes into your body. You are constantly on this heightened alert. And so the consequences are very serious with type 1 diabetes, right? If you cannot maintain, sort of this type of, I hate to use the word control because I think there's a lot of things that are out of your control when you have type 1 diabetes. But again, those scary things are sort of hung, not as a carrot, but I think sometimes in the past, people have thought that scare tactics are effective. Later, I'll talk about how they are ineffective, and we've seen that with research. But again, I think most people with type 1 diabetes, even if they're a young person, they know the dangers, right? Early death, hospitalization, amputation, blindness, kidney damage. The list really goes on for the consequences. Now, this last part, curability, controllability. So what is the patient's belief about a hope for a cure one day and keeping the disease in control, and how self-management can help them achieve either? So again, when somebody's getting diagnosed, or even if they're just struggling with sort of the day-to-day management of this disease, it's interesting to try to get into their mind to see how do they perceive this? What do they perceive sort of this long-term road that they're going to have to be on, right? Because living with diabetes is not a sprint. It is truly, truly a marathon. And so we need to really look at these 5 things and how that person is reacting. So we also know that these 5 components can change over time as the patient has new experiences that can be translated into either positive or negative, right? So what is kind of filling in those different boxes? We also know that results from their study showed if patients perceive things as problematic, they tend to have more negative effects on their life and will encounter more challenges as it relates to their health. I think that's really key to hear. Social learning theory. This term was coined by Albert Bandura. I'm very interested in self-efficacy. I find it very interesting, especially when talking in terms about then the management of this very complicated and curable chronic illness like type 1 diabetes. And so again, perceived self-efficacy, right? It is concerned not with what one has, but with a belief in what one can do with whatever resources one can muster. So the operative nature of perceived self-efficacy is an integral feature of the procedure used to access people's efficacy beliefs, right? So this theory has shown that unless individuals believe that they can create positive effects and dodge negative ones, they may not choose to act because of the lack of incentive in their own life as they perceive it. So again, are they being shown real life examples in their life? Again, we know a big burden about this with adolescents with type 1 goes to the parents or to caregivers in general, teachers, nurses, grandparents. So quite a long list. Can we put sort of this healthy perspective on how we're going to look at this diagnosis, this life, with trying to manage this complicated road? And so again, yes, you're never going to have a perfect day with diabetes. That's just something that's not even true. There is no perfection with diabetes. But again, okay, I have a bad blood sugar. My thing and my parents' opinion has always been, okay, what is the next best thing we can do? So we don't want to go days with sort of reckless, decision making, but can I reel it in quickly after I made a mistake? We also know from Albert Bandura, people learn a lot of their behaviors from their environment and how they observe things. So again, how behavior is modeled to them. We also know it can be highly influential if those guardians choose to send a child with diabetes to a diabetes summer camp. Again, if maybe that child in their own school district don't know a lot of people with diabetes, that parent though chooses to send them to, I went to a place called Camp Needle Point, bad name, great camp. And it was the first time in my life that I was around other women who were my age, teenagers, who had the disease, were managing it, were, dealing with it, overcoming it. And because I saw their behavior modeled, I could model similar behavior after them. And so that's a lot of what social learning theory goes into. And so again, it's how can we as parents, guardians, healthcare professionals empower the patient, so the child, to sort of take control of the disease. Again, making sure it's age appropriate, but making them feel a part of all those decision makings and not be so scared of the disease itself. And it's a very careful balance, and we'll discuss a little bit more of that later too. So we know that only 1/3 of children with type 1 diabetes achieve their targeted hemoglobin A1C. So we talked a little bit about the A1C earlier. Again, the diabetes community is trying to move more to a time and range model, but still the hemoglobin A1C is kind of what is looked at. The American Diabetes Association does the standards of care. So their 2020 standards of care, their recommendation for children with type 1 diabetes is an A1C goal of less than 7%. Now they say a higher target of 7.5 may be appropriate if somebody's experiencing extremely low blood sugars, or let's say they're having those low blood sugars and they're unable to detect it. We call that hypoglycemic unawareness. That does happen with people. So in that case, a doctor may say, let's have your A1C just slightly higher to make sure we're not having any of the dangerous consequences of undetected low blood sugars. But again, we kind of know where that target is and where we want to hit it. Now, again, only 1/3 of American adolescents are actually hitting that ADA goal. And so that is, what is concerning. And so to look at here, how can the family dynamics help get a larger number of children at more of an optimal level, is what we're striving for. So, and you may ask why. I'll go very quickly over why I think it's important. We know since '93, there's a landmark publication. It's called the DCCT. Many other studies as well, but the DCCT is the biggest. And it's overwhelming evidence that near normal glucose control diminishes the risk of retinopathy, neuropathy, again, blindness, liver damage, some of those things that we were talking about earlier. So we have studies to show that if we can keep somebody's A1C lower, they will have less complications and a better quality of life overall. So now we can see here that the A1Cs from people have done better, but we also see when we're looking at like the 10 to 20, that is where the A1Cs are the absolute highest. And so we want to see, again, with an adolescent, how can we best care for them? How can we best make sure that they're safe? But we want them to be healthy, right? So with family dynamics, I think we take a look here at what past studies have shown us. We look at real life examples. We know that studies have shown that how a parent models coping with the stress of a diagnosis can be a large indicator in how the child handles the diagnosis. So again, if a parent is super worked up and and again, I think any parent would be worked up having a child diagnosed with type 1 diabetes because it is super scary. But again, how is that parent coming off to the child is how maybe then the child is going to learn how to view their own illness. So depending on the family structure in the home, right, kind of who's the person who's in charge, or who is that child's kind of coach, right, who's helping them along with this, you can see higher rates of DKA and hospitalizations. Again, some research shows that the mother is predominantly placed in the position as the main communicator to the adolescent with type 1 diabetes. Again, we're looking at a very traditional home. Obviously there's a lot of different home lives that we can look at. There's a lot of different types of guardians. I know for me, my mother, for my younger brother and I, who both have type 1, she was our go-to person, right? She was the one who, if at school we got sick, had a bad blood sugar, she was the one called in because my dad worked full time. So we see because that role, she'll take on the task of learning about the disease so that she can assist the type 1 with the self-management. In doing so, though, it can isolate the mother from other members of the family from taking an active role in assisting with the child. We really want to strive to see how can we get the most members of the family involved, because that shows a greater sort of compliance, greater health for that child with type 1. But that's something that has to be done very consciously by families. And I also think for healthcare professionals, it's a really good thing to talk about when that child is diagnosed, or maybe if they even come to you and they're more of a recently diagnosed person, or let's say they've had the disease for 5-6 years, but they're coming into you, they're seeing issues, asking them about kind of who is that point person in your family who really helps you, who maybe sort of takes more of a backseat role, right? I think those are all really good questions to ask. So we know that, a lack of involvement between a mother and a child coping with diabetes can lead to greater depressive symptoms, and that collaboration, again, is associated with less depressive symptoms and more positive emotions, with support associated with less depressive symptoms for the child. And so again, a huge burden is put on one of those guardians. Helping the caregiver obtain age-appropriate independence while ensuring the child's safety. So again, my brother, when he was diagnosed at 5 years old, certainly should not have been, he wasn't sophisticated enough or had the knowledge to know how to, back in the day when you had to roll insulin and you had the clear and the cloudy and, you had to make sure you had so many units. Probably a 5-year-old in preschool isn't the best person to be doing that. But, okay, so that responsibility always went to my parents. But there were other things Will could pick. My mother let my brother choose his medical ID bracelet. What kind did he want to wear? She let him and myself choose what blood glucose meter. I remember being 13 and I picked out this purple meter. It seems massive now in comparison to what we have, but small little choices that are age appropriate, but getting kids involved in their diabetes care is crucial. Okay, so parents are placed in a really tricky situation. So while the adolescents with diabetes seek a degree of autonomy and self-management, natural parental fears incite a form of helicopter parenting. So we know how complicated type 1 diabetes is. We know the serious effects, coma, early death, hospitalizations, DKA, all these things are looming large. And so when I was diagnosed at 13, right, what did I want to do? I wanted to go to that junior high dance that night and be normal. But my parents, of course, had this incredible fear about letting me leave. What if I got a low blood sugar? What if I had a high blood sugar? What if I lost my supplies? And so you can kind of see this natural instinct of a parent to really helicopter their child in situations like this. But we know that children will resent that overbearance. And that children, based on research, can actually be stunted by that. Because again, either then there's an over-reliance on parents, or you as the child fear this illness. And so we know that there's a lot of issues that can stem from that. We also know at the same time, even though kids want nothing to do with their parents at certain ages, or a lot of ages, parents are an invaluable resource to that child. So when I was diagnosed at 13, I knew a little bit about diabetes because my little brother and babysitting him, but I was no expert. And so I had to rely on my parents in a lot of those situations to help me out. So we're looking at this really high level of nuance, which I'm sure, if you know this personally, you can probably count, however many examples that you know in your own life, in your own practice, with your own family, with your own friends. But there's a high level of nuance that's required for parents to try to strike this perfect balance between being the valued resource and allowing a child to take control of their own disease, right? And at what age do you flip some of those things over? Because then when I got a little bit older, my parents were very clear to me. Either if you can't learn, how to dose your insulin or check your blood sugar, fine. But that means that we'll be coming then to movies with you and your friends. We'll go to sleepovers, right? And so I had to acquire some independence and knowledge about the disease so that I could gain my parents' trust. And so again, that nuance, I think can be very tricky, right? But we know that when they collaborate with the type 1, they get the best results. Collaboration didn't stunt the child's autonomy, but is shown to facilitate more information disclosure to the parents. When a parent was viewed as intrusive and controlling, adolescents had adverse reactions. So I'll, a story that I know from a close friend of mine who has type 1 diabetes. She's probably late 20s. When she was first diagnosed with type 1 diabetes, a couple years in, but she was in middle school, she tested her blood sugar, and on the meter, I forgot what blood sugar was. It was in the 200s or 300s. It was a high blood glucose. And it had just read out, on the kitchen table when her father was looking over her shoulder, saw it. He picked up that meter because the blood sugar was so high, and he threw it as hard as he could against a wall, and the meter just smashed like in a million pieces, right? And he was livid. He was so upset. Now, of course, I felt terrible for my friend because she actually, over the years, and again, this is a very extreme case, but she stopped testing her blood sugar because she was so fearful, and she started equating a high blood sugar to be a bad thing. She started associating a lower blood sugar with a good blood sugar. She started feeling like she was a bad person when those high blood sugars will come up. And so she stopped wanting to test her blood sugar at all. So as she got older, when I met her, this was post-college, she had gone over 2 years without testing her blood sugar. Now, again, we could look at her and say she's not compliant. She's a double-digit A1C. She's not very good at her diabetes. Or if we peeled away some of those levels, we could say she had a very traumatic event with her father. Now, again, I don't blame her father, even though I wish he would have maybe done things differently, right? To not hurt her so much and her perception of the disease. But by him doing that, it really scared her. Now, again, I think he was just trying to helicopter. He was scared for his child. This disease can be very scary for all members. But we just have to be very careful how those things can come across, especially to children in those really sort of developmental, those key developmental years. We know that this balancing act is made more precarious because it can also affect a parent's own mental health, physical health. I'll talk about this a little bit later, when I did all these interviews with people, but definitely seen an impact on the guardian's health. Parents giving their type 1 adolescent autonomy may see an increased amount of stress for themselves. Parents who are especially protective or controlling their child may display less warmth. Again, we want to make sure that those relationships can be as healthy as possible. So how can we facilitate those in any medical appointment meetings, therapy appointments, nutrition appointments? Again, these overlying things that are happening and the relationships are going to impact everything. An old endocrinologist I had once say, if I don't know what's going on up here, I'll never understand what's showing up on your blood glucose machine. Meaning that if he doesn't understand the stresses in my life, what I'm going through, how others perceive me with diabetes, we'll never be able to figure out to get to that really happy place with diabetes. Now, just talking about type 1 diabetes is a debilitating enough. I mean, it's a tough disease. But then there's other things that layer on top of that that make it even more complicated. And so we know co-occurring illnesses, we know almost up to 50% of people with diabetes will experience diabetes distress at some point, so diabetes burnout. Up to 45% of people with diabetes have a mental health condition, okay? Some have cases of severe psychological distress that go undetected. We also know that they have a much higher risk for other autoimmune conditions. So again, we're looking at a whole other thing that could be kind of opening up Pandora's box. But we know that people with diabetes are at a higher risk for these other conditions, and that puts more stress, more pressure, more financial distress in on a family. And so I think we need to be aware of those things. So mental health, we know people with type 1 or type 2 are increased risk for depression, anxiety, eating disorders. Rates of depression 2 times higher. People with type 1 diabetes are twice as likely to have disordered eating. Women with type 1, bulimia is the most common. Type 2 is more binge eating. So it's estimated that only around 1/3 of people with diabetes and mental health conditions get the help that they actually need and that they deserve. And so again, that 1/3 number, that's not a good number, right? And I think we know as a country too, we have to do a lot better at treating mental illness, viewing it like we do with physical illness. You know, there's not a lot of people who would say, Quinn, don't take your insulin. But how many people would say, okay, Quinn, you're really struggling mentally. Let's have you go in and see a therapist, or let's have you go and seek treatment, right? I think we're certainly getting to a more acceptable level with those things. But we still see that there's quite a lot of stigma around mental health in our communities. And so I think we need to be really careful how we view it, how we talk about it, and knowing that there could be several layers for somebody living with type 1 and what they're going through. Financial distress, I could give a whole presentation on this. I know Tamara said I've done a lot with insulin affordability. I could do 2 hours on this topic, and I have a friend on this call, Sherry, who she's done a lot of the insulin affordability work with me, and we could go on a lot of tangents. That's not what this presentation is about, so I will not. If you ever have any questions, feel free to reach out to me though. But we know in America, price of insulin has skyrocketed 1,200% in the past 20 years. 40% of American patients with diabetes report a financial hardship, again, including patients with health insurance. I think we know in this country, just because you have health insurance doesn't mean you can afford healthcare costs. That is an understatement. 46% of people with diabetes have reported difficulty in affording diabetes. There's medication underuse, so insulin rationing. We know housing instability. We know even homelessness. 1 in 2 people with diabetes can't afford to get access to insulin. Only 15% of people with type 1 diabetes in the United States have a continuous glucose monitor. Only 3% globally can afford a continuous glucose monitor. So again, there's good technology out there, there's good insulin out there, but it's unaffordable to a lot of people. And that's irregardless if you have health insurance or not. And so that puts an added burden on a family and anybody with diabetes. Now, you know, my personal experience, you know, I've mentioned a little bit about this before, but my younger brother, Will, on the right, was diagnosed with type 1 diabetes when he was 5 years old. He was in preschool at the time. I was a 5th grader. We really didn't know anything about diabetes. We didn't have other extended family members who had it. So when Will was diagnosed, it was very serious. My mother tells this story about how they hospitalized Will for 5 days, mainly so that the family could figure out how to keep him alive with diabetes, right? So my mom had to learn how to test his blood sugar, how to dose insulin, how to give shots. My mother was deathly afraid of shots. And so this nurse had her practicing on an orange. And my mother, you know, looked to this nurse and said, I have no problem doing it on a nurse. My problem is having to give this to my cute, just turned 5-year-old. Like, that is unbearable. And this nurse looked at my mother and said, you know what, you can practice on me. And then this sweet old nurse rolled up her arm and let my mother practice on her. And my mother just broke down sobbing. But again, that kindness being shown for parents, that compassion to the guardians when a child is diagnosed is really key, because in a split second, you are having to change your life completely just to try to keep a child alive. Now, when Will was diagnosed, you know, my parents asked, what is the likelihood that, one of my other children could get diagnosed? That doctor said that would be impossible. He just said that wouldn't happen. Now, 2.5 years later, I was diagnosed with type 1 diabetes. At the age of 13. I was devastated. I was crushed. When I was diagnosed, my mom said something really interesting that's always stuck with me, and so I wanted to share it. My mother said the good news was we knew how to live with diabetes. The bad news was we knew how to live with diabetes, and how true that was. So she had already had 3 years of experience, living and helping manage Will's life, so they knew how to do it. They were confident that they could do it. But the bad news was she also knew the struggles that came with that and how heartbreaking that was. And so, yes, we could do it again. But for her, it was painful to have to see that. Now, some people have asked this in past presentations. There's a long-term research thing that's being done with diabetes called TrialNet with type 1 diabetes. So if one of your children has gotten diagnosed, would you bring in another child to get blood work done to see are they at a higher risk? I actually asked my mother recently if that was around when Will and I were diagnosed back in the 90s, would she have had me and my older brother go in? And she actually said she would not have, because she just would not have wanted to know. Again, I think that all comes down to personal preference in how you deal with that information, because I think some people do want to know. And so, it kind of all comes down to what works best for you. Now I'm going to go, I'm kind of segueing into talking about other people's stories and other people's experiences and how that really meshes with what we have seen here in research. I wrote a book several years back called If I Kiss You Will I Get Diabetes. Really talks about just the real life perspective of getting diabetes. But I won't read the chapter, but some of you probably heard me read this before, but I want to just hit on this story. Is people living with type 1 diabetes can present and show up in all different ways. And so for my younger brother, Will, that meant Will was very private with his diabetes. He always is. He just turned 30 this last week. He's doing great with his diabetes. He wears the CGM, but he doesn't want to wear an insulin pump. Works just fine for him, but he's not very vocal about it. So unless you knew him super well, you wouldn't even know he had diabetes. That is how Will lives his life. And I wrote a chapter about him in the book, just because I think it is so interesting that we grew up in the same house, had the same parents, the same medical care, the same opportunities. And I'm on the very opposite side of the spectrum as him, where I spent sort of my life advocating and volunteering and being a professional speaker, talking to medical professionals about how do we best treat people living with diabetes. Just because I kind of show up like that, as a shiny diabetes advocate, doesn't make me better or worse than Will. And so again, I think when we're dealing with different adolescents in different families, people deal with things different. They deal with emotions different. They deal with crippling diagnoses different. And so I think we have to do a people-centered first approach whenever we're discussing this, because one size won't fit all, unfortunately. Just like I'm sure all the parents out there know, each child is uniquely different, and that can be the case when viewing a disease like this. Oh, here's a picture now, obviously in my family, but my parents were very big on, again, we are not going to wrap you up in bubble wrap and put you in the basement to keep you safe. You have to prove to us that you can be responsible, that you can achieve things, and we'll sort of let your wings fly. That didn't mean that it was perfect every time. It also meant, though, if I had a high blood sugar, my parents wouldn't start yelling at me. We would try to troubleshoot the reason why I had a high or a low blood sugar. And so I was never afraid to talk to my parents about diabetes because I never thought I would get punished. So again, a lot of nuances there. I talked to several people just in preparation for this presentation, because I think it's great to hear research and see what those research studies show us, but also to look in these personal stories. Is it similar to what we're seeing in research? So this was type 1. Danny, was diagnosed with type 1 at the age of 13, has an older sister who's 4 years older. The parents described being terrified. They said they were paralyzed by fear. The mother had gestational diabetes, but when the daughter was diagnosed, she was just sobbing because she couldn't imagine even poking her finger when she had gestational. And she even actually brought up, this is not my mother, this is another story, but she said she was fine practicing on the orange, but when she had to start doing it herself, how just terrifying it all seemed. Financial distress, her and her husband talked about, do we sell our house? The type 1 child, we know kids are just sponges, even if we're not talking around them, they always seem to hear what we're talking about. The type 1 child felt really guilty for the debt because of them. The husband, we talked about adverse medical things that can happen to parents. The husband almost lost his eyesight because of the stress they were under. He still to this day has to get a $2,500 a month eye injection. She believes without type 1 diabetes, he would never had this medical issue. The more they learned, the more they got empowered. Again, the husband couldn't make all the appointments or even the majority. So the more they learned, the more inadequate he actually felt about his knowledge. And so she said, I can see how the more I learned, the more he stepped back and almost became more resentful of the position she was being put in. So again, really diving into each member of that family, how they perceive the child, how they perceive the diagnosis, how they perceive the care that is being given, and are people being included or are people being left out? It's very, very tricky, and there's no right answers and there's no wrong answers. And unfortunately, there is no playbook, unfortunately. I really loved when Danny's mom said this. Our daughter's life is more important than politics, greed, indifference. The only way to solve the problem is to keep advocating for accessible and affordable insulin and supplies, politely educating others, and striving every day to make a difference. Again, bringing your children's friends and their families along to become more educated, sharing what you've learned, to really include all people. This is Susan, a type 1 mom. All 5 of her children have type 1 diabetes. This is actually the only person that I know personally who has 5 children with type 1 diabetes. They were told before their children got diagnosed with type 1 diabetes that they had great insurance, right? What do we consider in America great insurance? That's quite an oxymoron, but I guess we can make a shirt out of that if we wanted. Each type 1 child costs roughly $1,700 a year. That's with health insurance. So, and they are absolutely terrified for when their children turn 26 in this country and are forced off their parents' insurance. They've already filed for bankruptcy. One of their type 1 childs got involved. They were involved in the community, and then one of their children got involved with drugs. Other families ostracized them. This mother said, we couldn't just send our type 1 child out on the streets. People just don't understand, right? So again, how different your life is from other families, and you may get judgment or opinions. This is from Cara. So she's a sibling of a type 1. Her younger brother, Jason, was diagnosed in the 70s when he was 4. Again, she talked about her mom having to become the dietitian, the nurse instantly. It was a lonely time for her. She had 5 children she had to take care of. So this is another mother with 5 children. Only one has type 1, but how distressing that is. And you look, okay, here we're talking about the 70s. The before slide, we're talking about 2021. Sadly, not a ton has changed. Yes, technology has gotten a little bit better, but it shows that these stresses are still very similar. So, the doctors kept sending him home, saying it was the flu. When he was finally diagnosed, he was in a coma. She talks about how her mom's whole life was devoted to making sure he was okay. Looking back, now she's an adult, she can't imagine the stress she was under. She said every family member was affected by this diagnosis. My dad felt he was gone a lot. He was always in the back because my mom needed to manage the disease. The mother never wanted to leave him alone. The mom wouldn't even let him attend Camp Needlepoint just because of her control. She was so scared and nervous. Again, that helicopter mentality. Even after he went to college, she kept worrying, and her stress contributed to poor health outcomes, right? And just really sad. So here's Chris. He has type 1. He's also a T1D dad. He was diagnosed at 8 over 50 years ago. Standards of care are totally different. But he talks about, we are extremely fortunate that his type 1 diabetes was in a good situation where he had seen me living with it and he had a very good idea what someone could do dealing with it. He did not let it have that great of an effect. He is far more open than I ever was about his condition. It's an interesting dynamic and relationship. So again, it was even an eye-opener for him when his son was diagnosed in 2004 and he has type 1. So I'm sure we can all imagine if you don't have type 1 and you get a child diagnosed, how scary. Rhea, she was diagnosed at 10. She's an identical twin, has a younger brother and a twin sister. She was diagnosed alone though at the time. So the mother had a newborn, 2 twins, and a new job. Extremely expensive first year. She was a nurse but didn't have a lot of knowledge about diabetes. Her husband though was very involved in the care, which is great. I asked about the effect on the other twin, and this mother said, and I think we heard this with other stories too, there is a lot of focus that goes on the child with type 1. It has to go there. Sometimes when your other kids are young, they don't understand why that attention is solely going to one child, right? So much attention on her, all these medical bills, and her twin, Lynn, really felt unseen, unnoticed, unheard. She felt she was in the back seat. Again, that other twin struggled with anxiety. The thought always was, when is this going to happen to me? And her mental health took a hit, and luckily they were able to bring her to a therapist. That twin was actually diagnosed with type 1 diabetes 3 years later after her identical twin, and the mother actually said that relieved some of the anxiety. But the third child always asks when he's going to get diabetes or when can he test his blood sugar. So again, just alternating dynamics always. Burnout, diabetes burnout, it's very real for both twins. This mother said, I try to combat it. If they ever ask me to take the wheel, I will. If that's decision making, if that's me putting in the bolus, or I'll do every site change they ask. I'll never let them know how tired I am. This has been helpful so they don't hit the teenage burnout as quickly. It is a partnership between us. So again, it's very difficult for this mom. She's not saying it's easy, but again, really trying your best to balance, having a good relationship. Also, as parents, as the guardians, you need to take care of your own health, because we know if the parent burns out, who does that child have? But again, we know financial resources are very limited typically. And so that is putting a whole other component. The mental health is a whole other component. And I loved when this mother said this to me. And if I could blow it up and frame it, I would. Our philosophy is kid first, diabetic second. And she said that her and her husband, Eric, sit down anytime the kids ask a question. That could be, can we spend the night at a friend's house on Friday? And even if that child's been struggling with high blood sugars, her and Eric sit down and say, okay, if diabetes wasn't in the picture, would we let our kid do X, right? And they typically say yes. And then how can they figure out to let this kid go to a sleepover or go overnight or whatever that is, right? Fill in the blank, allowing them to do that, figuring out the logistics, and as parents trying to do that so that they don't have to feel that burden, and that they can have quite a normal childhood, right? And I think that's really important. So I really loved that philosophy. I just thought it was good. And if I was a parent with a child with type 1 diabetes, I think that would be the philosophy that I would want as well. Other people, that I spoke to, I talked to a woman whose husband, her and her husband are both type 1. They have a stepdaughter with type 1. They notice when that child is in their house, things are a little bit better controlled. There's better accountability. Again, I'm sure there's more of an openness because probably that child thinks, these two parents understand it. They go through it every day. Hillary, she said, one thing that's very hard for my other kids is that the type 1 gets more attention in their eyes, right? And so, she talks about it as this abstract, nonsensical, kind of consuming, confusing thing, where you want to explain to your children that you have to put that extra attention on the type 1, but, sometimes it just, that means sort of neglecting the other children, and that can be hard. So how can we try to include them in things? That could mean inviting them to the diabetes walk. It could mean, you know, just getting them involved in different areas. So, you know, Deidre talked about how no one in her family cared or got it and how painful that was for her. Tina talked about how her father passed away, but what an impact that had on the children growing up, right? The time of day where you had to eat, what you had to eat, right? Everybody's life was impacted, regardless if that was the parent with type 1, if that's the child with type 1, that's both. You know, this girl talked about how her parents got up multiple times during the night to check blood glucose to keep her safe. You know, one woman talked about having a husband who's had type 1 since 18 months. It's totally affected the relationships in that family. You know, John talked about spending every afternoon from kindergarten through 12th grade racing home to make sure his mother wasn't in a diabetic shock or coma. Again, so looking at different lenses, different dynamics with a parent and a child, knowing how to call the cops, how to give orange juice to a parent, very scary. Jeff talked about how his mother paid more attention to him with type 1 over his brother. His brother, who's nearly 40 now, is finally just about to get it. Pam talked about having to cancel plans when blood sugars run high, headaches ensue. They're reluctant to make plans with others because of their children with diabetes. Now, this is from the Association of Diabetes Care and Education Specialists. This is the top 10 tips that they give parents when an adolescent is diagnosed with type 1. So 1, neither you nor your child did anything wrong. Again, I think there can be a lot of negative feelings because you think, why did my body do this to me? Why did I get this crappy luck? But nobody did anything wrong to get type 1. 2, you will adjust to your new normal, right? So Will now has had type 1 diabetes for 25 years. You know, you get into a routine, it does get easier. That doesn't make every day easy. That doesn't make every day fun, but it does become easier. Diabetes impacts the whole family. So like we talked about several times in this presentation, it's not just to the person diagnosed or not just to the parent who's kind of being the point person as the caretaker. It involves every member of that family, and getting family to get a better understanding will help you in the long run. One of the mothers, you know, talked about how her family doesn't get it, right? And thinks because she sees a nice photo of the daughter on Facebook, like an aunt does in another state, that then that child is fine and doesn't struggle at all with their type 1. So, you know, we need to refocus it, and we need to be great advocates for our children and for our patients. So 4, focus on the now. Again, what is the next best decision I can make right now? Let's focus on that. Diabetes is unpredictable. Geez, isn't that the truth? So there's some days I can tell you why I have a high blood sugar. There's some days that I have a high blood sugar that I have no idea why I have it. So again, riding that wave of emotion, those blood sugars, not putting that self-blame on is going to be really key. You are not alone. Number 6, as parents, as providers, as the person with diabetes, there's resources out there for you. You and your child will become diabetes experts. You'll be shocked. You know, I say all these kids with type 1, they're like mini mad scientists. They have an incredible amount of knowledge that they know about their bodies, about science, about technology. You will learn more and more. Taking care of your mental health and your child, I think this is absolutely key. I think everybody should be going to a therapist. So I think there's 2 kinds of people in this world, people who see a therapist and people who should go to see a therapist. So I'm always going to be a huge proponent of just making sure that you as a parent, that you understand that this is a big burden, and that you need to be looking after your mental health just as much as you are your child's. 7, support your child. So again, my parents, they send my younger brother and I a diaversary card and gift every year on the date that we were diagnosed. It's not to say you're perfect at this, but what it says is, we know by watching you what an effort you put in to be alive every single day with type 1 diabetes, and we're proud of you. So again, what are small things that you can do to support the child? And as healthcare professionals watching this, what can you educate those parents and those guardians with to help empower their children? And lastly, empower your child, right? So how can you empower them to test their blood sugar, to help you out with the dosing of their insulin? There's a lot of different things that can be impactful. Very lastly here, there's two books that I found that I really like that are children's books. One is Mommy Beeps. My stepdaughter loves this book, actually. So this is a book for children who love typically a parent with type 1, but it could be anybody. This is obviously about an insulin pump and a CGM beeping all the time. Just a really good book. Another book that actually somebody sent me was called Was It Something I Ate? Again, dispelling some of those myths out there around diabetes. So, but really good kids books that I've found are very helpful. So again, that's the conclusion. I have a couple minutes to take questions. I know we're running here at the very end. But again, there is such an incredible amount of kind of weeding through that you need to do when you see the family dynamic and when somebody is diagnosed with type 1. It's very difficult. There is no roadmap, unfortunately. I'm trying to give some suggestions and tips that I've seen in research and in real life that I think can be successful, because I know as a person with type 1 diabetes, you can lead a very fulfilling, very successful life, regardless of getting that diagnosis at a young age. So with that, I'll close. And if anybody has any questions, I would love to take them. Thanks so much.
Thanks, Quinn. We're at the top of the hour, and so I know if you're clinicians, you may have to hop off because you may be seeing clients, but we'll do a couple of questions. If anybody else would like to hang on for a couple of minutes, we'll do a couple of questions. Quinn, you talked about how important it is to get more family members involved in the care or support of the person with type 1. Do you have any tips for how to do that? How to get more family members involved in the process?
Yeah, so, I think sort of a classic example is you have a young child with type 1. Let's say the mother has been sort of tasked because she's more at home. So how would we get the dad involved? I think a way that you could get the dad involved is, by seeing, does he want to sort of take over some of the responsibilities on the weekends when he's not working, so that he feels like, again, he has a good understanding of the disease. He can also be helpful if the child ever comes and needs help. So again, I think empowering them even to have like one day a week or one night a week. That way he's involved, and again, doesn't feel like he's just taking a back seat and being neglected.
Right.
Also, inviting him to medical appointments would be my other suggestion.
And that tag teaming can really help the primary caregiver have some time and space on their own also, right? To rejuvenate and take care of their own mental health and self-care.
Yeah, I mean, I heard that over and over, and I saw it in the research too, that that sort of one caregiver is really burning out. Again, we also look at this financial distress. So what can we do to alleviate some of that stress on that primary caregiver? Again, I think it's empowering another parent, another guardian. If you're a single parent, could that be bringing in a grandparent or an aunt and uncle to help?
Thank you. Next question is, you talked a lot about support and how much, as you just said, the primary caregiver gives. As the type 1 person gets older and goes away to college, that must be a significant transition, I would imagine, for those parents who've been used to taking care of and worrying about their type 1 child. Do you have some tips about how to let go, really, and how to help parents know that that's an okay thing to do and have them feel okay about having their now young adult child go off to college or move away?
Yeah, so I'll tell you this, so I'm 35, my younger brother's 30. My mother to this day still keeps low blood sugar snacks in her purse for both of us. And so I think a type 1 parent just never never gives up that responsibility. They're always nervous, always kind of scared, always wanting to be that security blanket for the child. My biggest thing, because I do think that's one of the trickiest times, because you talk about a child having to leave adolescent care, moving to adult endocrinology, that's often tricky. Going to college is tricky. There is a tremendous resource in the College Diabetes Network. You can Google them. They have phenomenal resources for parents and for with youth going off to college. They have chapters around the country at different colleges and universities, but I think one of the best things that they provide is resources for that parent and very specific resources for the child going off to college.
Glad you mentioned that. Quinn and I have had the opportunity to work with the College Diabetes Network in the past and do some events with them. And they're a phenomenal organization that really provides, as you said, Quinn, not only support to the type 1 person, but to families. And they recognize how difficult it can be to let those folks go away to college. And then the groups that they have at those colleges and universities, which that list grows longer and longer every day, which is wonderful, is a great support system for someone who's going away to school and be able to have activities and have a ready-made group of friends that understand what they're going through. So I'm so glad you brought that up. Thank you, everybody, for attending today. We're so appreciative that you could be with us. Just 2 reminders again at the very end in case you missed it at the beginning. As soon as I click to close this webinar, an evaluation will automatically pop up on your screen. If you'd be so kind as to take 30 seconds or so to complete that, that would be really helpful. That's a continuing education requirement for us. It's completely anonymous, so feel free to be candid in your feedback. We tabulate those results and then send those to the CE entities. And then about an hour or so after the webinar ends, you'll receive a separate email from GoToWebinar. It will look similar to the email you received when you registered for this event. You'll get that email from GoToWebinar, and in that email will be the link to take the online test. You must take the test online in order to receive continuing education credit. Once you pass the test online, then your CE certificate will be automatically downloaded to your computer. If you don't see it, please check your downloads file because it could be hiding there. Okay, thanks everybody. We so appreciate you being with us. We look forward to having you join us for our 2022 webinars. In the meantime, everybody, please stay well. Bye-bye.